So in the technique where you place the mesh and you have a tunnel, if you will, where in the abdomen the ostomy runs between the abdominal wall and the mesh, are there any rules to guide where you place those sutures, how tight? You mentioned that in one of those patients that had the obstruction that the suture next to the bowel in that tunnel, if you will, was too close. How do you measure it? Is it gestalt? How do you do that?
Well, I can tell you that for our early experience, it was gestalt, and we're trying to actually standardize it right now because we've learned a lot, you know, in the first 20 patients or so. We place transfascial sutures, just like a laparoscopic ventral hernia repair, 3 to 5 centimeters around the mesh, and then we always place and by the way, this is all based on Henneford's paper in 2007, where he kind of described this technique. So it's not originally ours, but we do place 2 sutures next to the lateralized bowel, and I think that our fault in that first patient was we were more concerned about bowel slipping up next to that bowel, so we made it tight, but I don't think that's necessary. I actually think that I think that you should place sutures lateral to the bowel. I don't think it has to be tight though, because this mesh, this type of technique is actually like a flat valve. It works very well, so when the intra-abdominal pressure goes up, it actually pushes the mesh more into place, and I think prevents bowel then from sneaking up. So I don't think you need to make that too tight. The way that the bowel comes up to the abdominal wall and how much tension, I think it's very important to have that 5 centimeter overlap, but that can be difficult sometimes. I get a little concerned about angulating the bowel so much that, you know, that can obstruct people as well. So we try to actually orient the mesh kind of where the bowel wants to lie, and I think that that's important. We don't force the bowel to lie always in the inferior direction or always in the lateral direction or medial, but where the bowel seems to want to rest normally is where we'll have it lateralized. And so it's kind of a gestalt in answer to your question, but we are trying to find ways to standardize it because I do think it's a good repair.
Along those same lines, can you comment on the use of the tacker where you have a bowel tunnel?
Yeah, so we typically do use a tacker 1 centimeter apart around the outer edges of the mesh, and then as we get close to where that bowel is lateralized, we keep tacks away. I typically, when I do a laparoscopic incisional or ventral hernia repair, I will put double rows of tacks both on the outside and on the inside, but I get a little nervous on the peristomal hernias putting too many on the inside and staying away from the stoma, so we try to stay away from there. And I do think transfascial sutures are much more important than the tacks anyway, so if we leave a few tacks out, I don't think that's compromising the procedure, but I do feel that transfascial sutures are important.
Sounds like a wise decision. Middle microphone.
Michael Kia from Michigan State University. Couple questions. Your thoughts on your mesh choice was PTFE, using PTFE versus a coated polypropylene versus a biological. Any worry about infection rates, erosions?
Mm-hmm. Great question. I mean, so that was probably our biggest delay in actually adopting this technique, was this fear that we're going to have bowel resting against permanent mesh. I don't believe in biologic mesh for permanent repairs. I've heard people call it the most expensive hernia sac out there, and I kind of believe that myself. So we looked, you know, we did a literature search actually prior to going out seeing what mesh has been studied. There's been plenty of studies. Guy Voller, Carl LeBlanc have looked at different types of mesh, and I can tell you that polypropylene mesh is not a good idea. There have been several cases of mesh erosions and intercutaneous fistulas with that type of mesh. The dual mesh seems to be the one that has, you know, over and over again in peristomal hernia repairs showed not to have any of those problems. Obviously, there's less tissue ingrowth with that type of mesh, and that's kind of what you want with the bowel being on it. There are some newer mesh out there. There's some polyester mesh that have coating on it that now coat down the middle of the mesh on the side that's facing the bowel. I haven't liked that mesh because, and I haven't actually even used it, because I think what that does is take away your kind of ability to be flexible during the operation where you're going to have the bowel hang off. I think it would actually increase OR time because you'd have to make sure that mesh is perfectly aligned, bowel coming off perfectly in that little strip of covered mesh. So we've stuck with ePTFE because we've had no problems with it. And so I think that's the mesh to use in my opinion right now.
And then also the closure of the stoma. Do you think intracorporally closing it, the transfascial method of closing it, putting transfascial sutures next to through the
Yeah,
skin?
yeah, that's a great question, and we had the same fear. So we actually started the series by doing intracorporeal ties, and actually then expanded to doing extracorporeal ties. We try to stay as far away. If we can somehow get that incision to be away from where the appliance is going to sit and capture stool, you know, sitting right over that little hole, we try to do that. But we do use Dermabond, and you know, at the end, whether that makes a difference or not, I don't know. But we use Dermabond. We have not had any mesh infections or any problems so far with an extracorporeal way of tying.
Thank you.
And we use monofilament sutures.
Hi, Ilko Rassenaar from University of Washington. Thanks for the great presentation. I think definitely, in my opinion, also the way to go. Do you have any experience with ileal conduits and peristomal hernias?
Yeah, we didn't have any in this series with ileal conduits, but actually there's plenty in the literature. And you know, again, I would cite the Carolinas group actually had several in their case series of, I think, 25 patients or so, and they had a couple or three or so of ileal conduits, and I think I don't think it should add any difference to what we're doing here. Same ideas.
Right, thank you.
Should we be proactive in putting the Gore-Tex mesh in when we're doing our primary ileostomies?
Yeah, that's another good question. I know that there are some trials out there that are talking about randomizing patients to preemptive use of mesh versus not, and I think it's a little tricky subject, putting mesh in people before hernia's there. So I don't know the answer. I don't think anybody knows the answer to that, but there are people thinking along those same lines. I think it's an intelligent question.
When you did the stoma resightings, did you use mesh in any of those patients or bring the stoma through mesh?
Yeah, no, all of the stoma resightings in this group were done without any mesh at all.
And just one last question. How did you evaluate the recurrences? All by physical exam, CT, combination of both? And how do you classify prolapse without a true peristomal hernia?
Yeah, so that's a kind of a downside of this study in that there were 6 surgeons and these 49 repairs, and it was over the span of 7 years. And so we were very dependent on the medical record and the descriptions by both the surgeons in their final exam of that patient, as well as the radiographic recurrences were the easiest. And we're able to actually go back and look at films way back. So we're a little limited. We had to go by what surgeons said in their notes and whether or not patients required reoperation. And so whether or not that was truly a prolapse versus a hernia, I can't say for sure. That's the downside of a retrospective, of our retrospective data.
It can be evenly distressing for the patient, either one.
It's true.
Thank you very much. Nice presentation.
Thank you.
Well, as you mentioned, the last abstract was withdrawn, so that will conclude this session. Please have a wonderful afternoon. Enjoy the rest of SAGES. Thank you.